Hello, my name is Russ Amstead with the Targeted Infection Prevention Program study that is sponsored by Dr. Ilona Modi and others, and we really appreciate your attention this afternoon as we talk about some general principles about preventing transmission of infection and really advocating for the residents that you take care of at your facilities. We're going to discuss today really the chain of transmission and kind of look at how microbes get transmitted from one patient to the next or between residents, for example, in a long-term care facility. This is module number 2. Obviously, you've heard from Dr. Modi in module number 1 introducing the study. So we're going to spend some time really focusing on the chain of transmission and how microorganisms or germs get moved from one resident to the next, usually on the hands of we as healthcare providers during the care activities involved in long-term care and acute care facilities. So let's take a look at our first slide. This is the model for transmission of infection. It's called the chain of transmission, and as you can see, it has a number of links within that chain, and for there to be actual movement of the microbe and then infection possibly in the next patient or the resident, we have to complete all of these components of this chain of transmission. So this gives you an idea of some principles or concepts to really look at how do microbes move around in healthcare facilities. And in particular, we're going to be focusing on long-term care facilities. So when we first link in this chain of transmission, we're talking about the infectious agent or microbe. And as you can see here, there's a number of bacteria or germs that can be present in the environment in long-term care facilities. And those include certainly bacteria, probably the most common that you might encounter in a resident. And those are various types of gram-positive and gram-negative organisms. There's viruses, such as influenza is a virus that can also be transmitted. Fungi, rickettsia, and protozoa are other types of microorganisms. So I'll be using the term microbe. What I'm really referring to is a germ or a microscopic infectious agent that can cause an infection in a resident or a patient. Another important concept is looking at both endogenous flora and then also exogenous flora. So, and exogenous flora, for example, would be bacteria that are introduced to a resident from outside their body, so some other source of exposure. And that could be, here's an example that's presented in this slide, looking at methicillin-resistant Staph aureus or MRSA. That would be carried potentially from one resident to another on the hands of healthcare workers if they don't use good hand hygiene. So that would be an example of that, exogenous flora. Endogenous flora would be the type of microbes that you and I all have on our skin and in our bodies. We need those bacteria or germs to really have normal healthy status. So we do have a lot of organisms on our skin and in our body that are kind of part of our makeup. So the microbial flora is what we're really referring to here. Occasionally in long-term care facilities, we do see a change in the type of this endogenous flora. So we can see a lot of residents in long-term care facilities become colonized or actually have the presence of multi-drug resistant organisms such as methicillin-resistant Staph aureus on their skin or in their body. So there's some instances where we see a blending between these two, but a couple of important concepts just to think about in terms of if each of us have our own kind of normal flora, bacterial flora, and that obviously presents a risk for infection when we put in devices into patients, potentially allow bacteria to get into places where we don't want it to be present. So moving on to the next kind of link in this chain of transmission, the reservoir. So we have to have a source where the microbes are actually growing and replicating, or actually growing and kind of reproducing. So when we're talking about reservoirs of infection, certainly in humans we have our own flora that certainly is a reservoir where the organisms are present. And that on our skin, for example, we can have both transient or temporary flora, and then the other reference, not to be confused with residents you take care of, but we have a resident flora, which means microbes that are kind of normal parts of our skin microbial structure. So they stay there all the time in most instances, and they're usually part of the skin, the lower layers of the skin. You'll actually culture these microbes all the time. So transient is things that you can pick up by contact with surfaces, for example. Resident would be kind of your normal endogenous flora, for example, which I referred to in the previous slide. Certainly animals are a reservoir of potential organisms, so if you have a pet therapy program at your long-term care facility, animals certainly could be colonized or have microbes on their fur, for example, and you could pick that up through contact or petting of the animal. So that would be an example of one. And the other thing that I think most of us don't appreciate is the environment around your resident certainly is probably a source or a potential reservoir of microbes, including multi-drug resistant organisms. So things such as MRSA, another multi-drug resistant organism referred to as vancomycin resistant enterococcus, those can survive in the environment usually for some days, even up to several weeks, if they're not removed through good cleaning or disinfection. So the environment around the resident certainly could be a reservoir as well. Obviously, we're looking at trying to minimize contamination in those reservoirs of the environmental surfaces, and then handling of, we're trying to keep clean things clean, soiled things soiled, and we want to keep those two separated. So these are good principles that your infection preventionist at your long-term care facility obviously has already discussed these with you. And then finally, storage, it's important, same principles. Keep clean and sterile supplies separate from areas where you have contamination, such as the soiled holding room, or if you have a bathroom, for example, we don't want to have sterile supplies in the bathroom per se. So that's the reservoir of organisms. Moving on to a couple of important concepts around this reservoir is something here referred to as the iceberg effect, and that really kind of refers to colonization. So most of us probably have bacteria on our skin or inside our gastrointestinal tract, for example, so we're colonized with those organisms, and they're not causing active infection. The folks that have the active infection, say with a particular bacteria or germ, really represent just the tip of the iceberg. And this concept, I think, is important because there are a lot of residents in long-term care facilities that are merely colonized with multi-drug resistant organisms. They obviously represent a reservoir. If personnel, if you as the healthcare worker take care of one resident, don't use good hand hygiene, even if that resident has no obvious symptoms of infection, and go to another resident to manipulate a device such as a urinary catheter or feeding tube without using hand hygiene, you can move that bacteria from one resident to another. So this concept of colonization is important because we want to use precautions, especially good hand hygiene, whenever we take care of any resident. And we'll talk about how that impacts interrupting this chain of transmission. So infected, colonized, I'm sure you didn't think we'd be talking about icebergs today, but a useful concept in this picture I think brings it home in terms of what you have on your skin not causing active infection versus those that have active infection process ongoing. So that's the concept of the iceberg effect. Some key definitions of the differences between these two. Certainly colonization means the bacteria is present without evidence of active infection. So it's just on the skin, no active redness, irritation, or swelling, or breaks in the skin where there may be drainage. That would be an example of colonization. Infection, on the other hand, is indicative or indicates a real active infection is ongoing. And that's where the bacteria has gotten into the tissue and actually is replicating, causing damage to cells and tissue itself. So a good example of this would be if you have a resident who's got a break in the skin and there's purulent drainage from that skin cut, then potentially that would represent an active infection, not colonization. Likewise, if you have a resident who has an indwelling urinary catheter, they may complain of, or for example, without an indwelling urinary catheter, if the resident suddenly complains of burning frequency and urgency when they're urinating, that may be an indication of a possible urinary tract infection. So that's an example of bacteria that can be present in the bladder with no symptoms. That would be more of the colonization. When it begins to cause these symptoms of active infection, then we can be reasonably assured that we may have the presence of bacteria into the tissue of the bladder actually causing an actual infection. So those are some useful distinctions, I think, between the concept of colonization and infection. And as I mentioned in the previous slide, the infected, those folks with infection represent just the tip of the iceberg. Most of us have colonization with bacteria. An important reason this is being emphasized is that bacteria that are simply colonizing a resident certainly could be a reservoir and can be picked up and moved from resident to resident during the care activities in a long-term care facility or nursing home. So moving on to, we've got the kind of the infectious agent. We have a place where it's growing and replicating. How does it leave that person to get transmitted? There's a mode of exit. So that's the organism or the germ has to leave that one resident and somehow move into the environment or be moved to another resident. And how does that happen? Certainly here's some examples of that. So respiratory tract, if I have acute influenza infection and I cough or sneeze, I can release that influenza virus up into the surrounding area, usually within probably 3 to 6 feet away, and can release the influenza virus into the environment. So that would be an example of kind of release or exit of the organism from the person with the infection. Gastrointestinal tract, certainly if you've got a resident with acute vomiting, nausea, and diarrhea, that's another way for this organism to get out of that resident's body into the environment around that resident. So that would be an example of the gastrointestinal tract. Skin and mucous membranes certainly would be skin. Maybe we have an acute skin infection where there's drainage. Again, that bacteria in the drainage, there's a lot of microbes or germs present that can be released into the environment. Genitourinary tract, certainly blood, if you're doing blood glucose measurement in a long-term care facility and the lancet's contaminated with blood and it's on the tip of that, then there would be a potential mode of transmission in that situation. So it's left that person's bloodstream and is on a contaminated device. And then artificial openings such as a tracheostomy, or let's say we have a feeding tube in, there's certainly a way for bacteria under the skin or in the skin structures to get up around that catheter and be released into the environment. So those are the modes of exit. Even with that kind of release of the organism from the resident that might have the infection, we have to have a mode of transmission. So it's got to be moved from one location to the next before there's really kind of this piece in the chain of transmission to begin to complete this chain. So the mode of transmissions that we most commonly are focused on are really contact transmission, and that's got two modes. One would be direct, where I'd have direct contact, say with a draining wound. That would be an example of direct contact. Indirect might be the surface around that resident. Let's say the bed rails on their bed are contaminated with microbes. The healthcare worker comes in to do some activities of daily living with the resident. They touch the bed rail, don't use hand hygiene, then go to another resident. That would be a mode of transmission of kind of indirect contact. Droplet, I mentioned earlier about influenza. It really is coughs or sneezes is where the influenza virus is present. So if you're in a close proximity to somebody who's coughing and sneezing, and probably 3 to 6 feet away, that's where we would see the mode of transmission really through the air, but for very short distances, probably 3 to 6 feet. And then third most kind of typical mode of transmission would be true airborne. An example that we can point to very nicely is tuberculosis. So somebody who has active tuberculosis in the lung coughs quite a bit, and then they're producing the TB bacillus is actually getting up into the air. And what's unique about TB is it actually gets suspended in the air. So it could travel fairly large distances through the air from one room to the next, even through the ventilation system. So that would be an airborne disease transmission. For most of the residents in long-term care facility, and actually for that matter in acute care hospitals, we're really focusing on contact transmission in terms of the mode of transmission. Most of the organisms or multi-drug resistant organisms are actually picked up on our hands and moved from one resident to the next or one patient to the next. Other sources of certainly transmission would be what we call a contaminated food item, might be a foodborne or a vehicle of transmission. Those are unusual, but certainly one of the fourth modes of transmission. But the top three there are contact, droplet, and airborne. So we've got the mode of transmission, we've got the microbes on the move, as it were, and so how does it get from one resident to the next? It really has to have some way to enter the other person's body who's been exposed. So for an infectious agent that gets to a new resident or moves from one resident to the next, here's some examples of the way that would happen. You would breathe in, for example, when we talked about being close to somebody with active influenza. If you're within 3 feet, they cough and sneeze directly in your face. That would be an example of kind of the virus has moved to their respiratory tract and they've been exposed in that situation. An infection might happen. Gastrointestinal tract, obviously if we have a contaminated food item, we ingest that. That's how we would come down with kind of that type of infection. One thing we do see a lot in both acute and long-term care facilities, for an example here, would be norovirus. Does cause acute nausea, vomiting, diarrhea. That is usually a fecal-oral transmission. In other words, you've ingested the virus and it causes infection in the next person who's been exposed. Skin and mucous membranes, certainly non-intact skin, There's a break in the skin, which is probably our best barrier against exposure. If there's a break in the skin, it may be a way for the microbes or the germs to get into the skin and cause infection. Genitourinary tract, a good example, and one thing we're focusing on this study is when you put a device in a patient, it creates a way for bacteria to get into areas normally that are free of organisms. So for example, urinary tract, if we put in a urinary catheter, microbes or germs actually migrate along the catheter, get up into the patient's bladder and cause infection. And then blood, as I mentioned earlier, the contaminated lancet, if you as the healthcare worker accidentally get stuck with that lancet after it's been used on a resident, there's a potential exposure in that situation to a bloodborne virus, for example. So that's our mode of entry from really based on the mode of transmission that's gotten into the patient or the resident. And then certainly there's a lot of factors that go into our susceptibility. So I may be exposed to MRSA or have contact with a draining skin wound, not have any symptoms or even have any evidence of infection. In the long-term care facility, we've got a lot of folks who are potentially at increased risk, and those come from a variety of reasons. One of those is residents in long-term care may be very dependent on you to take care of them or help them out with activities of daily living. So that was one indication that there's a potential increased risk. Certainly immune system, so our ability to fight off infection if we do get exposed, begins to lose its effectiveness the older we get. So as we age, our ability to kind of mount a good immune response against in particular infectious agent drops considerably over time. Certainly barriers if they're compromised, so in residents in long-term care facilities, if they have very fragile skin and it gets torn, there's a barrier that's been broken which allows bacteria to get into lower structures of the skin, potentially cause infection. Urinary catheter, I made a good example there. If you put that device into a patient, likewise with a feeding tube, it's going through normal barriers that we have against coming down with or being exposed to certain bacteria that are in the environment around us. And then additional factors, certainly admission to a hospital is a risk factor for becoming colonized probably with multi-drug resistant organisms. So in acute care side in the hospital, we have as many multi-drug resistant organisms as you do see in long-term care facilities. One of the key distinctions is in acute care facilities, we have a lot of devices we put in patients. So very high proportion of patients gets an intravenous catheter put into them. We use a lot of urinary catheters, much more so than a long-term care facility. And we may do surgery where we actually cut the skin. So all those put you at increased risk of exposure. So when they come back to your long-term care facility, they may either be colonized, in many cases, with a new organism that they picked up in the hospital, or because of the susceptibility of this resident has become colonized with other bacteria or germs. Certainly the last one there, antibiotic use, very important to be very careful about who gets antibiotics, especially in healthcare facilities, long-term and acute care. What happens is the antibiotic actually suppresses some of that endogenous flora, what I call the friendly microbes that are there on each of us all the time. That helps prevent infection with some of these more unusual strains. When people are put on antibiotics, it suppresses their normal kind of microbial flora and allows for some of these multi-drug resistant organisms to show up. So that certainly is a risk factor for that resident. So how do we break this chain? I think the key thing is all of you are infection preventionists. So we're elated that you're participating in this study because it's very important to, you are the advocates and the folks that are protecting your residents who are under your care. And all of us have a very important role in infection prevention. So your facility may have an infection control coordinator or an infection preventionist who leads the program. We really depend on you that take direct care of your residents to interrupt and break this chain of transmission. The other key piece about this chain of transmission is just because I can culture Staph aureus from a bed rail, for example, or MRSA, doesn't mean it's going to cause infection automatically. We have to complete all these chains and this loop of transmission before we have a risk of actual introduction of infection. So let's walk through an example of kind of a completed chain of transmission. So we've got the infectious agent here would be methicillin-resistant Staph aureus or MRSA. The reservoir would be one of the residents' skin is colonized. They don't have active infection that we talked about colonization earlier. There's got to be a way for that Staph aureus or the MRSA to leave that one resident. So let's say they have an open draining wound on resident A would be a good example. They have a Staph aureus skin infection. It was cultured and it showed methicillin-resistant Staph aureus was present in that draining wound. A healthcare worker such as you or I came in to take care of resident A, took care of the wound itself, and after doing that we forgot to do good hand hygiene, such as putting on alcohol-based hand rubbing our hands to prevent that contamination on our hands. And we went immediately to another resident and they needed help with their urinary catheter, would be one of those examples. So what we've done is we've touched that urinary catheter or somehow manipulated that device and inoculated it with MRSA on the catheter itself. Over time, say a day or two later, that MRSA begins to migrate up along the catheter surface and actually get into the patient's bladder. So that would be the mode of entry for the next resident, which would be resident B. And then finally, because they have an indwelling urinary catheter, that sets up a risk for coming down with a urinary tract infection from the catheter itself. And then the final step here would be the resident B actually develops a MRSA UTI from that same strain that came from resident A. So this would be a dramatic example of direct kind of transmission from resident to resident, but I think it gives you a good picture of kind of how all these links in the chain of transmission could come together and result in a urinary tract infection, say in that second resident. So how do we break this chain? I think that's the key piece that we're asking you as part of the study to really help us focus in on how can we prevent transmission of especially multi-drug resistant organisms, but for all organisms, whether they're susceptible bacteria or resistant. We want to stop this movement of the microbe or the bacteria from one individual to the next. So for this example we just talked about, one area where we might break this chain would be the exit, so it's leaving that one resident A. So if we had good containment of that skin drainage on resident A, we may be able to prevent contamination of our hands, but also maybe the environment. So that would be an example of one place we could break this chain of transmission. Certainly the most important thing, and if you've heard this I'm sure at your facility, best way to interrupt transmission is good hand hygiene. No matter what the resident that we take care of before the next resident, if we use good hand hygiene, we're going to stop that transmission from one resident to the next. So usually with alcohol-based hand rubs, very convenient. It's probably the most effective way to do hand hygiene and the most efficient in terms of time. So some good principles. We'll be talking later in some modules about standard precautions and hand hygiene to really break this train of transmission, but we're focused really on this piece of the link, the mode of transmission. Another thought, looking at the resident, can we change that resident's risk of coming down or exposing them to bacteria or germs? And one way, if they have an indwelling urinary catheter, as you see here, if we remove that catheter, we minimize or lessen the risk of subsequent infection in that patient. So getting that device out when it's no longer needed, if possible, that's going to be an important way, again, another link in this transmission where we can actually break this, one of the chains here and prevent that movement of the MRSA infection from one patient to the next. So I want to thank you for your time this afternoon or this morning, depending on when you're listening to this. We have a live moderator with you to follow up on some questions and answers. And as I mentioned, our next module that we'll be talking about focuses on standard precautions and hand hygiene. Thank you very much and appreciate your efforts in infection prevention.